To this presentation on the origins of clinical engineering, focusing on the transformative period between 1856 and 1884. Today, we'll explore how military health reforms, particularly changes in medical examination protocols, played a key role in shaping the principles that clinical engineering would later formalize. Our focus is on the systematic revisions made to the hints on the medical examination of recruits for the Army, a critical military text that underwent multiple updates during this era. These revisions were not isolated administrative changes, they were responses to the evolving demands of military medicine during the Civil War and Reconstruction. What makes this period foundational is the convergence of several forces: the need for standardized, repeatable medical assessments, a growing reliance on objective diagnostic tools, and a strong moral influence from religious and civic institutions. These developments taken together laid early groundwork for clinical engineering, establishing the value of technical precision, ethical responsibility, and institutional trust in the use of healthcare technologies. Understand how medical examination protocols evolved during this period, we first need to look at the broader historical context. From 1856 to 1884, the United States was undergoing massive political, social, and institutional changes. The violence of Bleeding Kansas, followed by the Civil War from 1861 to 1865, threw the country into a prolonged state of crisis. These conflicts resulted in an unprecedented number of military casualties, many of whom returned home with long term injuries or disabilities. The sheer scale of human suffering exposed deep inadequacies in the military's ability to assess, manage, and rehabilitate its soldiers. In the aftermath, the Reconstruction era brought new challenges. As the country attempted to rebuild itself, the medical system, particularly medical military science, had to evolve. There was growing pressure to standardize care, improve medical preparedness, and support long term rehabilitation. These needs demanded more than intuition or informal judgment. They required measurable health criteria with reliable tools and systematic procedures, conditions that would eventually be met by emerging principles in clinical engineering. Key documents during this period was Hints on the Medical Examination of Recruits for the Army. Originally published in 1840, it served as the official guideline for military physicians tasked with assessing the physical fitness of new recruits. But what's most significant is that this document didn't remain static. It evolved. Between 1856 and 1884, it was revised multiple times, each update reflecting the changing demands and challenges of military medicine. The revisions in 1856, 1858, 1863, 1866, and 1884 track a clear trajectory from informal, subjective assessments to more rigorous, objective standards. These changes were driven by the realities of the Civil War and its aftermath. Medical officers needed reliable ways to evaluate a soldier's capacity to serve, both for initial enlistment and for managing recovery from injury or disease. We start to see the inclusion of quantifiable criteria, height and weight measurements, vision and hearing tests, and even early forms of urinalysis. These shifts present more than just bureaucratic improvement. They were early steps toward clinical objectivity. The goal was to make the medical evaluation process consistent, measurable, and defensible. This move away from personal judgment and toward standardized metrics mirrors the principles that clinical engineers now uphold when ensuring that diagnostic technologies are safe, accurate, and aligned with patient care standards. While much of the medical reform during this period was driven by practical wartime necessity, we can't overlook the powerful influence of religious institutions on the shaping of healthcare, and importantly, its moral framing. Religious organizations played a central role in providing hospital care during and after the Civil War. Churches sponsored field hospitals, operated convalescent homes for wounded soldiers, and supplied much of the volunteer nursing workforce. Their involvement wasn't merely charitable, it was part of a broader belief system that connected bodily health to moral character and spiritual readiness. During this time, physical fitness became more than a functional recruitment. It became a moral concern. The ability to serve, to work, or to recover from injury was increasingly interpreted as a reflection of personal virtue. This belief helped reinforce the legitimacy of medical examinations. Structured, repeatable assessments were not just about fairness or efficiency, they were viewed as safeguards for civic and moral order. Faith based support also helped normalize long term rehabilitation for disabled veterans, which further advanced the concept of systematic instrument based care. The moral weight that religious institutions brought to healthcare helped set the tone for what would eventually become clinical engineering, a field that remains deeply rooted in safety, service, and ethical responsibility. As we look at the military medical reforms of 1856 to 1884, it becomes clear how this period served as a prototype for many of the principles that now define clinical engineering. The push for repeatable assessments and the incorporation of standardized tools such as scales, height rods, vision charts, and urinalysis wasn't just a response to the needs of the war. It marked the beginning of a systematic instrument based approach to healthcare. These tools reduced variability and improved accountability, offering reliable ways to measure physical readiness and recovery. That's exactly the kind of thinking clinical engineers apply today, ensuring that medical devices function predictably, accurately, and safely across a wide range of patients and environments. These reforms also revealed the need for reliable diagnostic infrastructure. Military physicians learned that tools were only as effective as the systems supporting them. Documentation, maintenance, training, and oversight. This was an early form of systems thinking, a perspective that clinical engineers now use to manage everything from infusion pumps to imaging networks within complex healthcare settings. Perhaps most importantly, this period reminds us that technical innovation in healthcare is never separate from ethics and policy. Clinical engineers today carry forward that same balance, working not only to improve the performance of healthcare technologies, but to ensure those technologies serve patients ethically, equitably, and responsibly. Reforms between 1856 and 1884 transformed healthcare by introducing standardized medical exams that emphasized fairness, accountability, repeatability, and these changes built a lasting framework of trust in institutional care and laid the groundwork for managing technology with precision and purpose. Clinical engineers carry this legacy forward today, ensuring that healthcare remains ethical, reliable, and system driven.